Welcome back to the deep dive. Today, we're tackling something that, well, it looks simple on paper, but it's arguably the biggest silent killer out there, hypertension or HDN.
It really is the classic medical trap, isn't it? You see a blood pressure number, maybe two numbers, and think, okay, straightforward. But underneath that, there's this incredibly complex picture. Diagnostics, other conditions the patient has, and sometimes, yeah, really surprising causes that aren't about the heart at all.
Exactly. So, our mission today is to get past that sort of generic advice. We want to pull out the essential high-yield details that help you understand not just that someone has high pressure, but why and how best to manage it.
We're talking about when you absolutely need confirmation, how you can tailor treatment for maybe double benefits, and crucially, when to stop thinking primary HTN and start digging for a hidden cause.
Right, getting that structured, deep understanding that you as a learner really need.
So let's ground ourselves first. Definitions.
Mm.
Because even the numbers themselves, they've shifted quite a bit recently. Hypertension is generally defined as persistent blood pressure,
Mm-hmm.
and persistent is the key word there,
Mm-hmm.
at or above 130 over 80 millimeters of mercury. That's the current ACCHA threshold.
And that 13 to 80, that was a huge change, wasn't it? Suddenly millions more people fell into the hypertensive category compared to, say, 10 years ago.
A massive shift. Though, you'll still see some guidelines, like the older JNC8 using that higher 140 over 90 mark.
Yeah.
But the reason the ACCHA lowered it was pretty clear from the data.
Which showed.
It showed cardiovascular risk really starts climbing significantly once you
Yeah.
consistently cross that 30/80 line. So it highlights, the importance of catching it earlier
Yeah.
before things get really severe.
Good.
But the fundamental point, regardless of which guideline you're looking at, is it's not about one single reading. You absolutely need proof that it's persistent.
Okay, let's unpack this. If persistence is so key, the first big hurdle is that classic white coat effect. I mean, almost everyone gets a bit stressed in a doctor's office, right? And how big a deal is this, really?
Oh, it's a huge deal. That anxiety, the stress of just being in the clinic,
Yeah.
it definitely bumps the pressure up. We figure office BP readings are often, 5 to 10 millimeters of mercury higher than the person's actual average.
5 to 10 points? Wow.
Yeah, so think about someone who reads, say, 135 over 85 in the office.
Hmm.
Borderline right.
Yeah.
If you only use that reading, you could easily end up overtreating what we call white coat hypertension.
And overtreatment.
Yeah.
What does that actually mean for the patient? Just taking a pill they don't need?
It's more than that. It means
Yeah.
putting them on lifelong medication, potentially. That comes with side effects, costs, the hassle, the psychological burden of being labeled hypertensive.
I see.
Yeah, and studies suggest it could be as many as 20, maybe even 30% of people diagnosed just based on office readings actually have normal pressure outside. That's a massive number.
Okay, so confirmation outside the clinic isn't just a nice to have, it's pretty much mandatory to avoid this.
Absolutely essential. You want to avoid unnecessary lifetime treatment if you possibly can.
So what's the gold standard then? How do we really confirm it?
The best test, the absolute gold standard, is ambulatory blood pressure monitoring, ABPM. This is where the patient wears a portable cuff for typically 24 or sometimes 48 hours.
Mm-hmm.
It takes readings automatically, maybe every 15, 30 minutes during the day, less often at night. And this gives you a fantastic, comprehensive picture of their actual pressure trends, including, crucially, while they sleep and during their normal daily life, not just in that stressful clinic moment.
That makes perfect sense, but I imagine ABPM isn't always easy to get or practical for everyone.
That's true. It's not always available, sometimes insurance issues or patient tolerance. So the alternative, which is still very good and much more accessible, is structured home blood pressure monitoring.
Structured is the key word there.
Yes, definitely. You can't just tell them, oh, go buy a machine. You need to give clear instructions, like take readings twice a day, morning before meds, evening. Do it for a whole week.
Okay.
And they need to sit quietly for 5 minutes first, use the right cuff size, no caffeine or smoking for 30 minutes before, the standard stuff. Then, importantly, you tell them to toss out the first day's readings. Those are often a bit off as they get used to it, and then average the rest.
That level of detail is really important to get reliable data. What if neither ABPM nor that structured home monitoring is an option? Is there a fallback?
Oh, the last resort is going back to repeated office readings. But even then, you need to be strict about it. We're talking a minimum of 3 separate readings on different days, separated by at least a week.
Okay.
And ideally, you'd use an automated machine, have the patient sit quietly, alone in the room as possible, just to minimize that white coat influence as much as you can.
Mm-hmm.
The goal is always consistency and reducing that external stress.
So confirmation is the rule, almost always. But you mentioned exceptions times when the pressure is just so dangerous, you skip the waiting and diagnosing and you treat right away.
Exactly. There are really only two scenarios for that. Immediate diagnosis and starting treatment are needed only if the blood pressure is, frankly, sky high. We're talking 180 over 120 or more.
Wow.
Or, and this is crucial, if there's clear, undeniable evidence that the pressure has already caused end organ damage,
Yeah.
even if the BP isn't quite 180 or 120 at that exact moment.
Okay, let's define that. What kind of end organ damage signals an emergency?
We're looking for proof that the high pressure has already started harming key systems. So in the heart, that's left ventricular hypertrophy, LVH, which you'd see on an ECG.
The heart muscle thickening.
Precisely.
Yeah.
In the eyes, you look for hypertensive retinopathy, serious changes like bleeding, exudates, or even papilledema, which is swelling of the optic disc. And in the kidneys, nephropathy. That means checking creatinine levels, estimating GFR, and looking for significant protein in the urine, like a really high urine albumin to creatinine ratio.
So if someone walks in at, say, 12125, you treat immediately because the level itself is dangerous.
Correct.
But if they're maybe 159.5, but their ECG shows clear LVH and they have microalbuminuria,
Then the damage is already evident, the high pressure's effects are confirmed, and you also start treatment right away without waiting for more readings. The urgency is there because the damage is happening.
got it. That clarifies when to be aggressive. So once HTN is confirmed or diagnosed regently and maybe stabilized a bit, what's the essential initial lab workup? For someone newly diagnosed, uncomplicated case.
Right, the initial labs. The key here is that this isn't the time to start hunting for rare secondary causes. That's a common mistake. This first pass is all about assessing existing damage and checking for major related conditions.
Okay, so what are the pillars?
Three main things. First, check renal function. Hypertension hammers the kidneys. So that means electrolytes, sodium, potassium, but also calcium, which can sometimes hint at other things. Serum creatinine to figure out their GFR. And a urinalysis is essential, always with a urine albumin to creatinine ratio. Microalbuminuria is often the very first sign of kidney damage from HTN.
Because kidney health is so tied to long-term prognosis with hypertension. Makes sense.
Exactly. Second pillar, screen for metabolic conditions that often go hand in hand with HTN and ramp up cardiovascular risk. So a fasting glucose or an HbA1c to check for diabetes, which is incredibly common, and a full lipid profile cholesterol levels.
Standard cardiovascular risk assessment.
Right. And third, a baseline cardiac check. That means getting an electrocardiogram, an ECG. You're specifically looking for signs of that LVH we mentioned, the thickened heart muscle, or sometimes evidence of a prior heart attack the patient didn't even know they had a silent MI.
Okay, so renal, metabolic, cardiac, that covers the bases. But you emphasized not testing for rare secondary causes initially. Why is that such an important point to make?
It's really critical. Look, in a standard, newly diagnosed, otherwise uncomplicated patient, the odds of finding something like, say, a pheochromocytoma or Cushing's syndrome are incredibly low, less than 1% easily. So if you start ordering tests like plasma metanephrines or 24-hour urine cortisol on everyone right off the bat, you're going to get a lot of false positives. These tests aren't perfect, and a false positive triggers a cascade of more tests, maybe CT scans, more blood work, specialist referrals. It's costly, it causes anxiety, and it's usually unnecessary.
So the rule is, stick to the basics first.
Stick to the basics. Screen for diabetes, check lipids, assess kidney function, get the ECG. Only start the deep detective work for secondary causes if you hit specific red flags later on, like the hypertension is resistant to multiple drugs, or start really young, or there are other specific clinical clues.
Okay, that's a really practical point. Let's move into management then.
Yeah.
We've got the diagnosis, we've done the initial screen. If medication is needed, the guidelines point to 4 main first-line classes.
That's right. Those 4 big ones, the workhorses, are the ACE inhibitors, the ARB's angiotensin receptor blockers, the calcium channel blockers, or CCBs, and the thiazide diuretics.
The cornerstones. And often, just one drug isn't enough to get to goal, right? When should we be starting 2 drugs right from the beginning?
Good question. This is a key recommendation in recent guidelines
Right.
trying to combat what we call therapeutic inertia, not escalating treatment quickly enough.
Yeah.
The rule is, if the patient's starting blood pressure is significantly high, specifically if it's 20 points systolic or 10 points diastolic above their target goal,
Okay.
you should actually start with 2 drugs right away. Often, you can use a single pill that combines 2 different classes.
20 over 10 above goal, start 2 drugs. Why the push for that upfront combination?
Well, think about it. If someone's starting at, say, 160 over 100, and your goal is under 30/80, One drug might only bring them down maybe 8 to 12 points. They're still way off target. Starting two drugs from different classes, like an ACE inhibitor plus a calcium channel blocker, for example, gives you a much bigger, faster, and often synergistic drop in pressure. Getting them to goal quicker significantly cuts their long-term risk of stroke, heart attack, kidney failure. It's about being more effective sooner.
Makes sense. But before we even get to pills, or certainly alongside them, lifestyle changes are massive. Let's really dig into these non-drug measures. Their impact is often way underestimated, isn't it?
Hugely underestimated. Sometimes they can be as powerful as adding a medication.
So what's the number one most effective lifestyle change?
Without a doubt. Particularly for the huge number of patients who are overweight or obese, it's weight loss. Obesity drives up sympathetic nervous system activity, causes insulin resistance. Both things really push up blood pressure.
And how much impact can weight loss actually have?
It's significant. Losing just 10 kilograms, that's about 22 pounds, can lower systolic blood pressure by around 6 millimeters of mercury on average.
6 points. That's easily as much as some drugs give you.
Exactly. The ultimate goal we aim for is a BMI under 25. And we tell patients, look, this isn't just about your BP number. It's tackling the underlying metabolic issues that are driving the pressure up. For many people, especially if they're in that pre-hypertension stage, significant weight loss can actually normalize their pressure completely. Avoid meds altogether.
Okay, weight loss is king. What's next in line in terms of impact? Let's talk about the DASH diet.
Right, the DH diet, dietary approaches to stop hypertension. This one's another powerhouse. Following the DH diet properly can lower systolic BP by, estimates vary, but somewhere in the range of 8 to maybe 14 millimole Hg. That's a really substantial effect.
Wow, 8 to 14 points. Can you break down why it works so well? We hear low sodium, but you mentioned earlier it's more complex than just cutting salt, right?
Oh, it's much more than just sodium restriction. Yes, it's lower in sodium than the typical Western diet, but the real magic of DHH comes from what it's high in. It's packed with fruits, vegetables, whole grains, low-fat dairy.
So lots of minerals and fiber.
Exactly. It delivers high amounts of potassium, calcium, and magnesium, plus fiber. These are things the standard diet is often lacking. Potassium, for instance, helps your body get rid of sodium and also directly relaxes blood vessels. Calcium and magnesium are also vital for smooth muscle relaxation in the vessel walls.
Ah, so it's a combination.
It's the synergistic effect of all these nutrients working together. They help modulate sodium balance. They probably boost nitric oxide production, the body's own vasodilator. That's why just telling someone cut salt often doesn't work nearly as well as getting them onto the full DASH eating pattern. The overall dietary pattern is key.
That's fascinating. So weight loss plus DAH. For some people, that could genuinely be enough.
For many, especially with mild to moderate hypertension, yes. That combination could potentially get them to goal without needing any medication. It's a hugely important part of the toolkit.
Okay, what else? Exercise, alcohol.
Yep. Aerobic exercise, things like brisk walking, swimming, cycling, aiming for maybe 30 minutes most days of the week. That definitely helps. It usually gives a modest drop, maybe 5 to 7 points systolic. Good for vascular health overall.
And alcohol. This comes up a lot with resistant hypertension, doesn't it?
It really does.
Hmm.
Excessive alcohol intake, and the definition is typically more than 2 standard drinks a day for men, more than 1 for women is a major, but importantly, a correctable driver of high blood pressure.
How does it actually raise pressure?
It works in a couple of ways. First, alcohol directly stimulates the sympathetic nervous system, increases heart rate, constricts blood vessels.
Yeah.
Second, it kicks the renin-angiotensin-aldosterone system, the RAAS, into higher gear. That makes you retain fluid and boost pressure systemically. So chronically, heavy drinking not only makes hypertension worse, it actually makes the blood pressure medications less effective. The body's fighting against them.
So if I have a patient on, say, 3 different BP meds, an ACE, a CCB, a diuretic, and their pressure is still stubbornly high, like 155/95.
Before automatically reaching for a 4th drug, your very next step should be a really careful, non-judgmental conversation about their alcohol intake.
Right.
Because if they're drinking heavily, counseling them to cut back significantly, or maybe even stop for a period, could be the single most effective next step. You're addressing a root cause.
Okay, that really highlights the lifestyle factors. Now let's get into tailoring treatment. This is where it gets really interesting, matching the drug to the patient's other conditions.
Exactly. It's definitely not one size fits all. Choosing the right drug can sometimes solve 2 problems at once, or, crucially, avoid causing harm.
Let's start with the positive synergy. A patient with both hypertension and osteoporosis. Can we target both?
Yes, this is a perfect example. The preferred first-line choice here is generally a thiazide diuretic, drugs like chlorthalidone or hydrochlorothiazide, HCTZ.
And why thiazides specifically for someone with weak bones?
Because they have this unique side effect related to calcium. Unlike loop diuretics, which make you lose calcium in the urine, thiazides actually reduce calcium excretion. They encourage the kidneys to reabsorb calcium.
Ah, so they help the body hold on to calcium.
Precisely. And by doing that, over time, they can help maintain or even slightly increase bone mineral density. So you're treating the hypertension effectively, and you're providing a benefit for their osteoporosis, potentially reducing fracture risk. It's a fantastic two-for-one.
That's a brilliant example of smart prescribing. Now, let's switch to a high-risk scenario. Hypertension in pregnancy. This requires careful planning, right?
Absolutely critical planning. The main message for women of childbearing age with chronic hypertension is think ahead. If they're planning to conceive, or even if they're sexually active and not using totally reliable contraception, the medication switch needs to happen before they get pregnant, not after they miss a period.
So what are the go-to safe options during pregnancy?
The first-line safe choices are generally labetalol. That's a combined alpha and beta blocker. Extended-release nifedipine, which is a calcium channel blocker, or methyldopa, an older drug that works centrally. These all have pretty solid safety records in pregnancy.
And the drugs to absolutely avoid what are the risks there?
The avoid list is non-negotiable. ACE inhibitors and ARBs are category X, essentially. Especially in the second and third trimesters, they carry a major risk of causing severe kidney failure in the fetus.
The kidney failure, wow.
Yes, which leads to oligotracheos, not enough amniotic fluid. And that lack of fluid is critical because it prevents the baby's lungs from developing properly. It can cause fatal pulmonary hypoplasia.
That's incredibly serious.
Definitely. Also, spironolactone is avoided because it has anti-androgen effects, which could potentially affect a male fetus. Atenolol, another beta blocker, isn't preferred as it's been linked to fetal growth restriction. And while thiazides are generally first line for HTN, we usually swap them out before conception too, due to some theoretical concerns about reducing blood flow to the placenta. Stick with levolol, nifedipine, or methyldopa.
That really underscores the need for careful planning. Okay, third complex scenario. Pulmonary hypertension specifically caused by left-sided heart disease. This is called Group 2 PH.
Right, Group 2 pulmonary hypertension. This is a really important one to understand because treating it like other forms of PH can be dangerous, even lethal.
Why is that? What's the underlying problem?
The core issue starts in the left side of the heart.
Yeah.
Typically, the left ventricle is failing maybe from long-term untreated high blood pressure itself or valve problems or a heart attack. Because the LV can't pump blood forward effectively, pressure backs up into the left atrium.
Okay, pressure backup.
That high pressure then gets transmitted backwards into the pulmonary veins, causing congestion in the lungs. And that congestion raises the pressure in the pulmonary arteries. So the high pulmonary pressure is secondary to the failing left heart.
I see. And this affects the right side of the heart too.
Eventually, yes. The right ventricle isn't built to pump against high pressure. Over time, that strain causes the RV to dilate and fail, leading to signs like swollen neck veins, JVD, and leg edema, classic right heart failure signs.
So the pulmonary hypertension is just a symptom of the underlying left heart failure.
Exactly. Which means the #1 management priority is always treat the left heart failure first. You need guideline-directed medical therapy for heart failure. ACE inhibitors or ARBs or ARNIs, beta blockers, diuretics is needed. Improve the left heart function, reduce the backup pressure, and the pulmonary pressures will often come down naturally.
And you mentioned a crucial warning about using standard pulmonary hypertension drugs here, the vasodilators.
Absolutely critical warning. Pulmonary vasodilators drugs, specifically designed to open up the pulmonary arteries, are contraindicated in Group 2 PH. They are dangerous here.
Why? What happens?
Think about it. The left ventricle is already failing, it's overloaded, congested, it can't handle the blood it's already getting. If you suddenly give a drug that widens the pulmonary arteries, you essentially dump a whole lot more blood very quickly from the lungs back into that already struggling left ventricle.
Oh, like flooding an engine that's already stalled.
Exactly. It overwhelms the failing LV, dramatically worsening the heart failure and potentially causing sudden life-threatening pulmonary edema, flash pulmonary edema. So in Group 2 PH, you treat the left heart problem, not the pulmonary arteries directly.
That distinction is absolutely vital. Okay, let's shift gears. We've covered primary HTN management, but sometimes the pressure stays high despite multiple drugs or it shows up unexpectedly young. That's when we put on our detective hats, right? Hunting for secondary causes.
Precisely. This is where the real deep dive detective work comes in, especially when you have resistant hypertension, meaning uncontrolled pressure on 3 or more drugs, ideally including a diuretic, or when hypertension develops very early, say before age 30, or very late and suddenly.
Where do we start the hunt?
Often the first place to look is external factors, drugs, and substances the patient might be taking, sometimes without realizing the connection.
Like oral contraceptives, we touched on this. It's a known cause in young women. What's the mechanism again?
It's the estrogen component, primarily in combined OCs. Estrogen stimulates the liver to produce more angiotensinogen. That's the precursor molecule for the whole renin-angiotensin-aldosterone system, the RAS.
So it basically revs up the body's main pressure-raising system.
Exactly. More angiotensinogen means more angiotensin II, which means more vasoconstriction and sodium retention. The longer the exposure, the higher the risk.
And the first step isn't necessarily adding a BP med.
No, the first step is simple. Stop the estrogen-containing contraceptive. Switch to a non-estrogen method like a progestin-only pill, an IUD, or barrier methods. Often, the blood pressure will drift back down to normal over weeks or a few months. Only if it stays high after stopping the OC do you need to consider antihypertensive meds.
Okay. What about other substances? Cocaine use. What are the telltale signs?
With acute cocaine use, you're looking for hypertension, often severe, in a younger person, typically under 30. But look for the cluster. Extreme tachycardia, maybe visible tremors, sweating, psychomotor agitation, they seem really revved up, and a specific clue, especially with snorted cocaine, is recurrent nosebleeds, epistaxis.
And the mechanism is just a massive adrenaline surge.
Pretty much. Cocaine blocks the reuptake of norepinephrine and dopamine at nerve endings. So you get this huge flood of these stimulating neurotransmitters hitting the receptors, causing intense vasoconstriction and driving the heart rate and pressure way up.
Now, there's a critical management point here regarding beta blockers, the danger of unopposed alpha activity. Can you explain that clearly?
Yes, this is crucial, potentially life-saving. If someone comes in with a hypertensive emergency clearly related to cocaine, you must avoid giving a beta blocker by itself, especially a non-selective one.
Why is that so dangerous?
Because cocaine stimulates both alpha and beta adrenergic receptors. Alpha-1 receptors cause vasoconstriction, tightening blood vessels. Beta-2 receptors cause vasodilation, relaxing blood vessels. If you give a beta blocker, you block the helpful vasodilating effect of the beta-2 receptors.
Leaving only the constriction.
Exactly. You leave the alpha-1 receptors completely unopposed to the massive norepinephrine surge. The result is intense, uncontrolled vasoconstriction, which can actually make the hypertension worse, dangerously so. It increases the risk of things like stroke or aortic dissection.
So what should be used?
First, confirm with a urine drug screen if possible. Treatment focuses on calming the sympathetic storm, usually with benzodiazepines like lorazepam or diazepam. And if a vasodilator is needed, you'd use something like phentolamine, an alpha blocker, or nitroglycerin. Avoid isolated beta blockade.
That's a really important clinical pearl. Okay, moving away from substances, what about sleep issues? Obstructive sleep apnea, OSA.
OSA. This is incredibly common, maybe one of the most common causes of resistant hypertension, and yet it's still frequently missed. The link is very strong.
How does poor sleep translate to high blood pressure?
It's all about those repeated episodes during sleep where the person stops breathing the apneas. These cause drops in oxygen, hypoxia, and rises in carbon dioxide, hypercapnia.
And the body reacts to that as stress.
As an emergency, basically. Each time the oxygen level plummets, the body thinks it's suffocating and triggers a big surge of stress hormones, catecholamines, to wake the person up just enough to take a breath. This happens over and over, sometimes hundreds of times a night.
Wow.
These repeated surges lead to a state of chronic sympathetic nervous system overdrive that persists even during the daytime when they're awake. That's also why many OSA patients lose the normal dip in blood pressure that should happen during sleep.
So treating the sleep apnea could actually fix the resistant hypertension.
Absolutely, often dramatically. If you suspect OSA, look for the classic signs. Loud snoring. Partner reports pauses in breathing, excessive daytime sleepiness despite adequate hours in bed, often obesity, large neck circumference.
Right.
The diagnosis needs a formal sleep study, polysomnography. And if they have significant OSA, treatment, usually with CPAP, continuous positive airway pressure, can lead to significant improvements, sometimes even complete resolution, of their resistant hypertension. It's treating the root cause again.
Okay, let's turn to conditions affecting the blood vessels themselves. Fibromuscular dysplasia, FMD, who gets this?
FMD is something to think about, particularly in younger patients, especially women, typically between ages 15 to 50, who present with resistant hypertension. Importantly, it's not atherosclerosis, not plaque buildup. It's a different problem where the artery wall itself develops abnormally, often with fibrous or muscular thickening.
And it hits the kidney arteries.
Most commonly relevant to hypertension, yes. If FMD affects the renal arteries, it narrows them, reducing blood flow to the kidney. The kidney thinks the whole body's pressure is low, so it cranks out renin, activating the RAAS and driving up systemic blood pressure.
But FMD isn't just in the kidneys, right? That's a key clue.
That's often the distinguishing feature. FMD also commonly affects other arteries, particularly the carotid and vertebral arteries going to the brain. So the clinical picture might be resistant HTN plus neurological symptoms like TIAs, mini strokes, unexplained headaches, neck pain, or this really specific symptom, pulsatil tinnitus.
Hearing your own heartbeat in your ear.
Exactly. If you hear that cluster young woman, resistant HTN, maybe weird headaches or pulsatil tinnitus FMD should be high on your list. Diagnosis is usually confirmed with imaging like CT angiography or MR angiography, which might show a characteristic string of beads appearance in the affected artery.
Okay. What about the other main cause of renal artery narrowing, especially in older folks? Renal artery stenosis, RAS.
RAS is much more common overall and typically affects older adults, usually over 55 or 60. Unlike FMD, this is usually caused by atherosclerosis plaque buildup, narrowing the renal arteries, often in patients who already have evidence of plaque elsewhere, like coronary artery disease or peripheral artery disease.
What are the red flags for RAS specifically?
Suspect RAS in an older patient with resistant hypertension, especially if they also have episodes of unexplained flash pulmonary edema, sudden severe fluid in the lungs. Or, classically, if they develop acute kidney injury, a sharp rise in creatinine, shortly after starting an ACE inhibitor or an ARB.
Why does starting an ACE inhibitor cause kidney injury in RAS?
Because in a kidney with a tight stenosis, its blood flow and filtration pressure are critically dependent on angiotensin II, constricting the outgoing blood vessel, the efferent arteriole. ACE inhibitors block angiotensin II, that efferent arteriole dilates, the pressure inside the kidney's filter drops, and filtration plummets, causing acute kidney injury.
That makes sense. Is there a specific physical exam finding for RAS?
Yes, it's quite specific if you hear it. A continuous abdominal bruit. Not just a bruit heard during systole, when the heart pumps, but one that continues through both systole and diastole. That continuous whooshing sound over the flank or upper abdomen strongly suggests turbulent flow through a narrowed renal artery. It's a key sign.
Good to know. Okay, third vascular cause, this one genetic, autosomal dominant polycystic kidney disease, ADPKD.
ADPKD is one of the most common serious genetic disorders. It causes numerous fluid-filled cysts to grow throughout both kidneys, eventually leading to kidney failure in many people. But importantly for our discussion, it often causes hypertension quite early on, sometimes years or even decades before kidney function significantly declines.
How do the cysts cause high blood pressure?
It's thought to be related to the cysts expanding and compressing the surrounding kidney tissue. This compression can cause local ischemia, reduce blood flow within the kidney, which again triggers the kidney to release more renin, activating the RAS and pushing up blood pressure.
What's the clinical clue on exam?
The kidneys can become massively enlarged. So in some patients, you might actually be able to feel these large, irregular masses in their upper abdomen when you examine them palpable kidneys. That, combined with early or resistant HTN and maybe a family history, points towards ADPKD.
And if ADPKD is diagnosed, there's a critical screening test needed that's not related to the kidneys.
Yes, absolutely. Patients with ADPKD have a significantly higher risk, maybe 5 to 10 times higher, of developing brain aneurysms, specifically baryaneurysms in the circle of Willis.
Which can rupture.
Exactly, leading to a potentially devastating subarachnoid hemorrhage. So screening for intracranial aneurysms, usually with MR angiography, is recommended, especially if there's a family history of aneurysms or stroke, or if the patient is undergoing major surgery.
Okay, last category. An endocrine cause that seems totally unrelated at first glance. Primary hyperparathyroidism, PHPT.
Right, this really shows how systemic blood pressure regulation is. PHPT is usually caused by a small benign tumor and adenoma in one of the parathyroid glands in the neck, causing it to produce way too much parathyroid hormone, or PTH.
And PTH controls calcium, right? What's the connection to blood pressure?
The excess PTH leads to high levels of calcium in the blood hypercalcemia. And it's the hypercalcemia itself that seems to drive the hypertension.
Oh.
High calcium levels can directly affect the smooth muscle and blood vessel walls, making them constrict more easily, increasing peripheral resistance. It might also make blood vessels more sensitive to stress hormones like adrenaline and potentially increase renin secretion from the kidneys too. So multiple pathways.
What's the classic clinical picture for PHPT?
The old mnemonic was bones, stones, abdominal groans, and psychic moans. But more subtly, you look for the triad of hypertension plus hypercalcemia, blood calcium plus maybe kidney stones. Fatigue, depression, constipation can also be features.
And the proof that the PHPT is causing the HTN.
The proof often comes after surgery. If the patient has the parathyroid adenoma, surgically removed a parathyroidectomy, the hypercalcemia resolves, and frequently the hypertension dramatically improves or even goes away completely. It confirms the high BP was secondary to that little gland in the neck, a truly correctable cause.
Amazing. What a tour through the complexities hidden behind a simple BP reading.
It really is a deep topic.
Okay, let's try to wrap this up. Key takeaways from this deep dive. What were the most surprising or high-yield points? For me, the absolute mandate for out-of-office confirmation because the white coat effect is just so common and leads to overtreatment.
Absolutely. And I think the elegance of using thiazides for patients with osteoporosis, that dual benefit is clinically really satisfying.
Yeah. And then the whole detective work section, remembering to actively screen for things like cocaine use, or especially OSA, in younger patients or those with resistant hypertension before just piling on more drugs.
Right. Don't just treat the number. Figure out why the number is high, especially when it's behaving unusually.
So if we connect this all back to the bigger picture, managing hypertension, it's really less about just hitting a specific number and more about understanding where that pressure is coming from systemically and what consequences it's having.
Exactly. It's about tailoring your approach, understanding the patient's whole physiology, their bones, their pregnancy plans, their sleep, even their parathyroid glands. It all potentially plays a role.
We saw how direct vascular changes like atherosclerosis and RAS or the vessel wall changes in FMD cause HTN. But then we saw how something seemingly miles away, hormonally speaking, like a parathyroid tumor, can also be the root cause.
Which leads to a really interesting final thought, doesn't it? When we treat hypertension with our standard drugs, are we just, managing the plumbing, tweaking resistance, adjusting volume? Or in some cases, are we actually indirectly counteracting these complex hormonal signals or sympathetic drives that were triggered by something completely non-cardiac?
That's a great question. What underlying mechanism, maybe something totally unexpected, could be influencing blood pressure in you, the listener, or in your patients without anyone realizing it? That's something to think about.
Definitely food for thought.
Well, this has been incredibly insightful. Thank you for joining us for this deep dive into the nuances of hypertension. We'll see you next time.